That's just my iPad, OneNote. I make big notes on it. Yeah. Take this off.
So we're going to start in about a minute.
Okay.
Just to let you know, we do have a map that you can use to point at any time.
Okay.
So it's only on this screen.
Yep. Shows up over there. Shows up on that.
You're saying that we do have a mouse for you to use. If you need to point to something.
And that one shows up there. Okay. Did you figure out what to say about the disclosures?
I'm just going to say that the disclosures have been scrolling.
Yeah.
They're on the iPad.
Yeah.
And this is supported by an educational grant by Community
Yeah.
Village.
And I've noticed it's not just our disclosures, but
Yes.
all the
Yeah.
people at the tables too,
Right.
the facilitators. Their disclosures are circling too.
I can say faculty and
Yeah.
facilitators.
Yeah. No one can see me. Look at this. Can't see.
Good afternoon. Whoa. Good afternoon, and welcome to this workshop on keeping pace in the timely detection and neuropathological diagnosis of Alzheimer's disease with practical strategies for integrating biomarkers into diagnostic workflows. That's a mouthful. We're very excited to be offering this workshop today, and if you like this program, you can come back for dinner. Tammy's cooking up something really good later in the same room later today. So I'm happy to be sharing this program with Sharon Shaw and with Tammy Benzinger, and also many facilitators who are at tables who will be working with you in small groups coming up. Our disclosures for both the faculty and the facilitators have been scrolling. They're available also on your iPad, and we want to welcome everyone here in this room, but also people who are joining us online for today's program. Okay, so we want to acknowledge our facilitators and take a moment and look at their names here. Thank you so much for helping out with this program. You can also visit us at peerview.com, and thanks to Peerview and the organizers and to the Association for supporting today's program. You can view the slides and the practice aids now and download them after the event. You can also visit pace-alls.com for additional educational activities, practice aids, and other resources on Alzheimer's disease. Let's start with a polling question so you can get in the practice of it. Which of the following are barriers or challenges that you experience in your practice? 1, availability of testing modalities to confirm a diagnosis of Alzheimer's in a patient with MCI or mild dementia. 2, issues with reimbursement for testing modalities used to confirm the diagnosis of AD in a patient with MCI or mild dementia. Or 3, difficulty in interpreting and sequencing testing strategies used in the workup of patients with MCI. So please vote if you would. Okay, so there are a lot of votes. It looks like it adds up to about 180%. So 2/3 of people thought availability of testing modalities, 3/4 issues with reimbursement, and over 40% difficulty in interpreting and sequencing testing strategies. So all of the above. Our goals for today's program are to enhance your understanding of the relationships between specific AD biomarkers, the underlying neuropathologic changes that define Alzheimer's, and the clinical manifestations and severity of cognitive and functional decline, and increase your ability to employ validated biomarkers to make an accurate diagnosis of AD in patients who present with symptoms of cognitive impairment. One of the real problems with, I think you all agree that we're at a transformative time in the Alzheimer's field, where we have new diagnostic tests which are increasingly sensitive and hopefully increasingly available, and also disease-modifying treatments to help slow the disease process, and new treatments being tested that can hopefully add additional benefit. One of the real problems is with early diagnosis. So looking at the data on this slide, only a small percentage of individuals with MCI actually get a diagnosis that they're having mild cognitive difficulty, and it's woefully underdiagnosed in a primary care setting. And when more specific tests are used, such as PET or fluid biomarkers, that improves diagnostic accuracy and management. I want you to think about a patient example that we'll be talking about later of someone who comes in for a diagnostic evaluation and how she might be evaluated, what the options are. And we'll give you different scenarios in our breakout session with this patient for further discussion. So just to be thinking, this patient is a 66-year-old black woman with 16 years of education. She's had memory difficulty for 6 months with some difficulties with multitasking. She has hypertension, type 2 diabetes, arthritis, controlled on medication. Her screening laboratories are normal. She's on lisinopril, metformin, and aspirin. And her mother had onset of dementia at around age 80 and died of breast cancer. Her father had a stroke. And she had a MOCA done, in her primary care office, which was 22. She's had some mild symptoms of depression and anxiety, some minimal difficulty, functional difficulty with her taxes, and her MRI scan shows mild to moderate bilateral parietal atrophy, a little bit of frontal atrophy, some mild bilateral hippocampal atrophy, some mild to moderate small vessel changes, and she has two small lacunar infarcts, one in the left putamen and the other in the right cerebellum. So someone we're very likely to see in clinical practice. She's concerned and she wants to be further evaluated. So be thinking about her as the program progresses. I'll turn this over to Dr. Sha.
I'm never tall enough to go behind a lectern, so I'm right next to it. Hope you're enjoying your lunch. Save some food for me. So I don't need to explain the neuropathology of Alzheimer's disease. I see a lot of familiar faces in the audience, so you guys are experts here. But just as a reminder, as a framework, as we go to talk about these cases and the discussion, we know, and especially with the updated criteria, we know the pathology includes the amyloid plaques and the tau tangles, and we're starting to be more inclusive to think about the synaptic dysfunction, neuronal injury, and how that interplays with neurodegeneration. And that bottom figure there is really highlighting that we're starting to have more biomarkers to understand not only inflammation and toxicity, but co-pathology, such as synuclein and TDP-43. And as a reminder of the clinical stages of Alzheimer's disease, we have the preclinical stages, and there's a lot of discussion about what stage 0, stage 1, and 2, but 1 and 2 are really when we have biomarker evidence of the amyloid and tau, but we don't have clinical symptoms as of yet. So the stage 1 is really saying they're asymptomatic, but stage 2 is suggesting that the patient does have a decline in the previous level of cognitive function, but they're performing normally on cognitive tests. And they're performing normally essentially on measures of daily function. Whereas mild cognitive impairment is the stage 3, and then stage 4, 5, and 6 are in the dementia range. And what we are discussing today are the amyloid targeting therapies that are really focused on the stage 3 and 4. Now, as a reminder of where we were in 2018 with the ATN framework of the classification of the biomarkers of amyloid, tau, and neuronal injury, both CSF and imaging, now we're thinking about these as we bring forward some new biomarkers that we have in development and in clinical practice today. And as a reminder on that x-axis of time, that preclinical Alzheimer's disease, mild cognitive impairment, and then progressing on to dementia with a biomarker change. And we know that the amyloid is what's depositing first in the brain, and we can detect it in different ways now: plasma, CSF, and PET. And then a little later is when we're starting to get the tau changes, and then we see the neuronal injury with hypometabolism on FDG PET or atrophy on MRI, and then we start to have the cognitive impairment as well as dementia. So if we're thinking about that left side versus a little bit in that middle versus later is where we're starting to get into the core 1 and core 2 biomarkers we're seeing in the new classification criteria that were just published, and Cliff Jack gave a wonderful presentation yesterday about that. And here's this, and you have this practice aid available for this table. And just to break it down, those core 1 biomarkers in the top versus core 2 biomarkers are really trying to compare that in terms of the clinical staging. That the core 1 is what we can detect earlier, and the core 2 is a little bit later that tends to correlate with what we see on tau PET. And then we have in that sort of lower middle the biomarkers of nonspecific processes involved in Alzheimer's disease, and then co-pathology such as synuclein and vascular disease. And we're going to get into that a little bit more in depth. And another table here as a reminder of these core 1 and core 2, and it really took me time to sort of process to understand what the core 1 and core 2 is really thinking about. Those core 1s are correlating best with that amyloid deposition, because that's what's changing first. Now we see that with amyloid PET, as we understand, it's been available and now available clinically to order, that's reimbursed. And that also includes these p-tau species. Even though tau is in the name, it really correlates best with the amyloid PET deposition. And then in the core 2, a little bit below, is what correlates most with the tau PET and comes back a little bit later. And then but we don't have a lot of other biomarkers besides tau PET, such as the MTBR 243, that's the microtubule binding region 243, as of yet in the clinical practice. And as a reminder of the staging, the ABCD in the new criteria, what we see is that that's really representing the tau deposition as it progresses through the disease. So stage A is really amyloid, but we don't see tau deposition as of yet, and we don't have markers to detect that. Stage B is then when we have medial tau deposition, medial temporal lobe tau deposition. Stage C is more intermediate when it's having more cortical deposition, and then stage D is a high neocortical diffuse spread of that tau deposition throughout the brain. So that ABCD is really trying to represent that Brock staging of the tau deposition, though knowing that there may be patients that don't really match that staging perfectly, such that there may be people that have more tau representation but are clinically much milder, or vice versa, that we don't have as much tau deposition, but they have a lot more clinical progression, which may represent co-pathology or other pathologies at play. And you have that as a practice aid as well. And then this figure is really demonstrating how the tau burden can really impact and predict cognitive decline in these patients. Now, on your iPad, before we move on, let's take a moment to answer a follow-up poll question on the role of tau PET in the diagnosis and staging of Alzheimer's disease. Basically testing your baseline knowledge or whether I explained that very well. Is that available on your iPad?
What?
Tech issue to a table at group 2.
Well, is it more?
Oh.
No, it's more widespread.
Uh-oh.
Now, what was that crash that affected people worldwide? What was that called, except for Southwest?
I guess if
So the
their iPads
yeah.
work, go
Okay.
ahead and answer it.
And then we'll move
keep
on.
going.
Okay.
Yeah.
So here's apologies for the tech. So it must be some hacker. Another practice aid available is really understanding that now we have biomarker testing. In this era of amyloid targeting therapies, we can detect. Obviously, we need to make sure that someone has amyloid in the brain before we give them an amyloid-reducing agent, and we can detect that by amyloid PET, CSF, and now plasma test. And the caveat here is that there isn't an FDA-approved plasma test yet available. And now on to Dr. Benzinger.
Yeah, so just, specifically discussing amyloid PET in the clinical context of working up a patient. So we have in the United States several tracers for amyloid PET that are FDA approved and are clinically available. And this is just showing you some examples of those, of what a negative and a positive amyloid PET scan looks like. So, just by way of background, I think we're all very familiar with the fact that these amyloid PET agents were approved based on autopsy data, so correlations with postmortem studies showing that amyloid pathology is present. And of course, from all of the years of research that have brought us to this point in the field, we know now that this amyloid positivity can take place 10 or 20 years before somebody has clinical symptoms. Many of us are familiar with the work of the IDEAS study, which was performed before we had treatments available. But even in that era where we didn't have a disease-modifying therapy, the amyloid PET scans were found to change the managements of patients presenting with MCI in about 60% of the cases and 63% for dementia. And that's even before we had immunotherapies. And just a reminder again, each of these scans, the way that they are evaluated is based primarily on a visual read system, and that's part of their FDA approvals. They have slight differences in terms of how long they take, and they get read by expert readers who've gone through specific training for those. And so these are just links you can go back to in the practice aids later if you're interested in learning more details about that system. And then I also wanted to bring up the Salloway scale. So this is a question we get a lot because for the most part, what we're seeing in our clinical reports is a visual read, positive or negative, but what we had in clinical trials was something called the Salloway scale. So the Salloway scale is a way to harmonize the results across the amyloid tracers, and is a continuous scale. And if you look across various neuropathology studies, and then look at what have been used in clinical trials, usually a range between 20 and 30 is what's being used as a cutoff, with a Salloway of 20 correlating to moderate neuritic plaques at autopsy. There's now at least one approved software that can give you a Salloway value in your clinical report, and there are others in progress. So over the next year, I think we'll see multiple options available for this and ways that you can request that in your practice if it's helpful to you when you're evaluating these patients that come in. For tau PET, we only have in the United States one FDA-approved tracer, fludarabine. And it also has an approved visual read system and training scales that can be done. And I do want to point out, so for any of you in the audience that are in the imaging space clinically as researchers or radiologists or nuclear medicine physicians, the ALSNet webpage has really incredible resources integrating a lot of these things about how to get training, how to figure out which MRI protocol to run, things you can install on a scanner, links to reporting templates, and so on. So this is very specific to the imagers in the audience, but go back to these links if that applies to you.
Okay, excellent. Thanks, Tammy. So in addition, as you're aware, in addition to PET, we have CSF, assays that are FDA approved, and that correlate. There's a very, not a perfect correlation, but there's a high correlation between CSF biomarkers and PET biomarkers. One of these assays is a ratio of A beta 1 to 42 over A beta 40 in CSF, which has good sensitivity and specificity and is FDA approved for the diagnosis of Alzheimer's disease. A second is a combination assay that includes p-tau 181, total tau, and also as a ratio of p-tau 181 over A beta 42, which also has very good, especially the ratio, has very good sensitivity and specificity for amyloid status. And this is the type of report you might get from that hybrid assay, where there'd be a readout about the overall, the ratio, the A beta score, the total tau score, and the phospho-tau score with norms for each to help you interpret the results. Now, as you're aware, we've made amazing progress in plasma biomarkers, and among these, the p-tau 217 has been sort of the most productive and robust assay, and will increasingly, it's not yet, none of these are FDA approved yet or covered consistently by insurance carriers in the United States, so there's still some barriers there, but they are available, and we can order them, and they're looking really good. And even as of yesterday, we had new data about the performance of the PRECIVITY-2 assay. So I think we can use these tests now for screening. We do use these tests now for screening, certainly in clinical trials, to try to decrease the amount of PET scanning that is required. And we can feel pretty confident if the values are elevated or low, clearly elevated or clearly low, that the person either it will be amyloid positive or will not be amyloid positive, and they would not require additional PET scanning unless we needed that PET scan to monitor treatment response. There may also be patients in the intermediate range who may need additional testing. So a nice report with Suzanne Schindler and Oscar Hansen as the first authors just came out, recommending screening versus confirmatory tests and how to use plasma testing. And we'd like to have results that are similar to CSF or PET, greater than 90%, greater than or equal to 90% sensitivity and specificity, so we feel confident in using them as a confirmatory test. And I think will be part of the discussion today with our case example, but also increasingly for all of us, we'll have to figure out how to factor this into clinical practice. I mentioned there are a few assays there are many assays actually, and so that's another issue we're going to have, is deciding which assay to utilize in practice. Some use a mass spec technique, others are immunoassays that build on the existing structure that may already be available to a healthcare system, and they're looking good. So there's another, iPad's still out? Okay, is that true? iPads aren't working right? Okay, so I won't ask you to take this polling question then. They are working? Raise your hand if your iPad's working. Okay. Well, anyway, feel free to take this next polling question if your iPad is functioning okay. So this is just a list, and this again is available in your practice aid, of assays that Tammy mentioned. There are 3 amyloid PET assays that are FDA approved. There's one in the United States, one tau PET assay that's approved. There are 2 CSF assays that have FDA approval, and a number of assays, especially plasma assays, are either CLIA certified or have received FDA breakthrough status, but are not yet FDA approved. And hopefully that will be coming before long. Okay, there's another, again, if your iPad is working, there's another question for you. Okay.
All right, so we've kind of gone through the core 1, core 2 for the new diagnostic tools and thinking about how those might apply to patients presenting in our clinics. What we want to move to next is that next set. And so I want to start with, at the bottom of that new framework, we have our old friend, the clinical MRI scan. And I think the key here is we're still using MRI in the diagnostic workup the same way we've used it for a long time. So a lot of it is to rule out other pathologies, be that current or past trauma or a tumor or some other lesion. We also can use MRI to look for features consistent with Alzheimer's disease, such as hippocampal atrophy. But I think most important as we're moving into this era of immunotherapies is to remember that we need that MRI to also address whether this patient might be eligible to go on to a therapy. And to do that, you need to make sure the MRI protocol is adequate to address specifically the microhemorrhages. And many times that general brain protocol for dementia might not have included the right sequences and protocol for that. So we do encourage you to think about using this MRI for both purposes so that you don't have patients need double visits or repeat imaging or repeat work. And again, if you go back to that link to the ALSNet resources for imaging, it can help you find out exactly how to do that.
So just as a reminder of that bottom table in that new framework for the criteria, that we have other biomarkers, and this is a non-specific marker. So neurofilament and light chain is just a reminder that it's a non-specific biomarker of neurodegeneration that we see elevated in Alzheimer's disease, but we also see it elevated in other neurodegenerative diseases. You see highest here in this table is frontotemporal dementia, but you can see it elevated in many others, so non-specific. Similarly, glial fibrillary acidic protein, that was really hard to say quickly, as an inflammatory biomarker that we can detect in plasma, but again, it's non-specific, that we see it elevated in Alzheimer's disease, but we may see it in other non-AD degenerative diseases. And then finally, biomarkers of co-pathology. We had a lot of great sessions this morning and yesterday about looking at synuclein. So we have synuclein seed amplification assays that are now available both in CSF and in skin to really detect and address co-pathologies. And we don't have a lot of answers as of right now whether these amyloid targeting agents are appropriate for people who have co-pathologies, so it may be helpful to understand whether your patient has a co-pathology or not. And so now, we could be introducing the small group?
Go ahead.
So now we'll be breaking out into your small groups. And guess what? Your table is your small group. So you will have a facilitator at each of your tables. We will also be facilitators going to a table. And everybody has a case, but there are 3 different versions. And we have about 10 minutes to discuss, and then we'll bring it back to the larger audience to discuss some interesting discussions that you have related to these cases.
So think for the group, think of as your discussion is progressing, 1 or 2 key points that you think it would be good to communicate with the larger group about this case and how you might approach the challenges of it, so that we can share and discuss further. Anything else housekeeping we have to do before we start the small groups? Ready to go? Okay.
All right, we start the time.
Okay, 10 minutes. Have at it.
All right, if I could have Dr. Sha and Dr. Salloway come back up front. And then if we could have the table leads kind of gather up. We've got 3 groups and 3 microphones. So if our facilitators could get together, we're going to be asking for some comments and feedback. So first up, just some comments and feedback from the table. And I'm going to start with group 3. We have Dr. Raji from St. Louis.
Hello. Testing, testing. Okay. So we had 8 tables that did a great job working through the case. And in our case, we had an amyloid positive PET scan. And in conjunction with the other history items, I think a couple of things that came up in our discussion is that, number one, the use of apixaban, by far, as an anticoagulant, was the most concerning element of history that would make to the decision not to treat with an amyloid-targeted therapy. However, there were other points that were raised about the presence of the mild to moderate white matter hyperintensities, the ApoE4 positive status that could increase the risk for amyloid-related imaging abnormalities. And I think some of the things that came up in terms of other information that the groups wanted to see was the susceptibility-weighted imaging that would have shown the microbleed burden. And I think ultimately the decisions of the group was to do more lifestyle-based modifications as this patient was well medicated for her diabetes with metformin, as well as her blood pressure with lisinopril. And also the other observation made by the tables was the fact that in many cases, this is a really typical example where you won't have pure Alzheimer's disease, but a mix of vascular risk factors superimposed onto the Alzheimer's disease, which then really influences a close examination of these factors to determine treatment pathways.
Thank you. I would just want to make a comment that Group 1, Group 2, and Group 3 have similar cases, but not exactly the same. So some people did not have the apixaban in her medical history with atrial fibrillation. So we have this up on the board now, so that can be a frame of reference for Group 1 and Group 2 who didn't have that case. Thank you so much.
Thank you.
All right, do we have I'm blinded in this corner. If one of the Group 1...
Oh, Dr. Schuyler Scott from Group
got one?
3.
Okay.
Yeah, thank you.
Hi, my name is Irina Schuyler Scott from Stanford and from Group 3. So our patient was the one who was on apixaban and had a positive amyloid PET scan. So first, we all determined that we thought that this was MCI due to Alzheimer's disease, given the MCI, the pattern of atrophy, the positive amyloid PET scan, and the E4 status also was consistent with that. We didn't want to order any more tests, and in fact, some question whether we would order the amyloid PET scan to begin with, given that this patient was on apixaban and we knew that she wouldn't be a candidate for an anti-amyloid therapy. And we also all agreed that we wouldn't offer her an anti-amyloid therapy given that she's on apixaban and that's exclusionary. We did have an interesting discussion about circumstances where patients can come off their anticoagulant, for example, if they get a Watchman procedure or something along those lines, or conversations with cardiologists. And as far as the question about have you experienced any challenges in ordering these tests, whether it's ordering, billing, reimbursement, et cetera, the answer was all of the above.
Can I just ask a question from your table? Was the group unanimous about the not wanting to pursue anti-amyloid treatment because of the E4 and the apixaban?
I think that we determined that it's based on provider comfort. If it's just the question of whether to recommend it based on the E4 status on its own, but because this patient was also on apixaban, it made the decision a little more black and white.
I'll just add that the plurality of tables by far recommended not to treat, but even if the apixaban hadn't been a factor, there were severe concerns about the ApoE4 status, as well as the mild to moderate small vessel disease and the aggregation of multiple vascular risk factors.
Interesting.
Thank you.
Keep going, you guys are doing great.
All right,
Should we go to...
maybe go over to Group 1.
Yeah.
Certainly.
Introduce yourself, too.
Yeah, please.
Yeah, this is Greg
many bright
Day,
lights.
I'm a behavioral neurologist at Mayo Clinic in Florida, and we had a very productive discussion in Group 1. I think the differences between the case in Group 1 our patients had a CSF study. She has a borderline, or a low amyloid and a borderline amyloid to p-tau181 ratio. You're literally at the borderline, the kind of point none of us like to see in clinical practice. She's also had an infarct that involves a cognitive network and is presenting with presumed amnestic MCI. And so the discussion really revolved around what is the cause of her MCI. Certainly introducing vascular disease or mixed vascular Alzheimer's disease is a possibility. And there's some assumptions that the patient's interested in considering treatment and learning if treatment will be beneficial for her, and a general agreement in our group that further testing is needed. We're very thankful that we have access to additional tests here, amyloid PET being the preferred modality that our group would have pursued, while simultaneously investigating and evaluating those vascular risk factors. And so introducing those conversations, assessing current management of diabetes, hypertension, thinking about sleep apnea was a good point that was brought up, and taking time to do the lifestyle discussion, either inside of the visit or at centers that have resources outside through some additional counseling there, to really keep our focus on treating the whole patient while we wait for the results of additional tests.
Love that.
Yeah.
That's really great.
How about other Group 1 perspective?
Can I just ask a question?
Yeah.
From that? Thank you. Was there a feeling that she was a good candidate for amyloid-lowering therapy?
The feeling is that we're not certain she's amyloid positive yet. So if there's amyloid to lower, I think our group is open to having that discussion with this patient.
So if her PET, because Tammy mentioned about the Salloway scale now being available in the clinic, if her amyloid PET scan was ordered and it came back at the Salloway's of 35, because she does have this, intermediate result on the CSF.
Yeah, I would have to take that back to the group. I think I'd be going for some consensus discussion there and see what folks thought.
Okay, excellent.
Good PC answer.
That was.
Any other Group 1 comments?
Yes, so,
He has one.
can folks hear me?
No.
Louder.
Hello?
Yeah.
Okay.
Yeah.
So Trey Bateman, I'm a behavioral neurologist at Wake Forest. We also had Group 1 and essentially agreed with the same conclusions that Dr. Day just said. We talked about, we didn't assume that it was an amnestic MCI because it wasn't clear. So one thing that we discussed was better characterization of the cognitive syndrome. Is this somebody who's presenting with a dysexecutive syndrome with two infarctions that could potentially contribute to a primary dysexecutive syndrome? We talked about maybe considering additional testing with amyloid PET given the intermediate result. We also had some discussions about maybe even looking to FDG PET to try to identify where the spatial abnormalities are on that. Is this something that's consistent with an early Alzheimer's disease with posterior hypometabolism or not? And evaluating for things like sleep apnea, depression, et cetera, that might be contributing to this presentation. And we likewise waffled a bit on whether we thought moving forward with an anti-amyloid therapy at this point would be warranted. I think very borderline with her. It's such early abnormalities with the biomarkers that I wouldn't typically expect to see this driving as much cognitive dysfunction. So I would have to convince myself that I thought the syndrome she was presenting with was causally due to that underlying amyloid pathophysiology or Alzheimer's pathophysiology.
Great.
And we had also, in Boansis at WashU, we also had case 1. I think the other point that we discussed in it is that for some of these values, she's African American, and we don't know what those values are as well in certain groups. And so there was some discussion. It was very mixed. Some were, in our group, were saying that they would go and treat. Others wanted more confirmatory tests. I think there was also a discussion, as Trey and as Greg were saying, neuropsych testing and then ApoE4 status would be important if we were to be treating this individual. And then even on imaging kinds of tests, as we heard with case 3, there would be additional information on SWIs or DWIs to further characterize if this was individual was going to receive therapies, and counting that and knowing that ahead of time for treatment.
All right, that's great. So now let's move toward the middle here.
Justin Long from WashU. Group 2 had a slightly different case. This individual had mild to moderate small vessel disease and 1 lacunar infarct, did not have a history of atrial fibrillation, and the biomarker test that was completed was a blood-based biomarker test where the result was a clearly positive result. So we, like other groups, felt that the etiology was probably a mixed etiology, although the blood test, assuming it was a high accuracy blood test, would be consistent with the diagnosis of Alzheimer's disease, although we felt it would be important and helpful to have additional neuropsychological testing to help guide what contribution of cognitive symptoms might be attributable to the underlying Alzheimer's disease. Assuming the blood test was a high accuracy blood test, we felt comfortable proceeding with using that test alone. If it was a less accurate blood test, then a amyloid PET scan or some other follow-up test would have been helpful. We agreed that lifestyle interventions were very important for this patient given her degree of small vessel disease. But assuming that the blood test was accurate or a follow-up test was positive, we would feel comfortable in this patient proceeding with disease-modifying therapy, although we would want an ApoE genotype test first to confirm her baseline risk based on her genotype.
Thank you.
So you'd be comfortable treating this patient based on the blood test alone?
Depending upon which blood test was being used, if it was validated.
If you felt,
Yeah, that was the consensus.
that the assay was reliable.
Yeah.
All right, Dr. McKay?
Yeah, Dr. McKay from Washington University. We were a little different. We were also in group 2. We decided that the positive p-tau 217 test probably did show Alzheimer's disease, but that they would need further testing to confirm that, especially if you wanted to do anything with therapies. We would order, I guess, tau and amyloid PET scans to confirm basically whether or not it was just at the amyloid stage or whether tau had begun. We would also want to be confirming, well, the prevalence or the positivity rate, cutoff rate for people of minoritized populations. We want to make sure that we are actually assessing someone as positive for their, for what we would expect in their group, and so that was something that we wanted to maybe get amyloid PET for. In terms of what plan of care would be recommended, or what the future going forward would be, they would want it baseline MRI to look for microhemorrhages in case of a risk of ARIA if we were doing anything with therapies, ApoE genotyping, tau PET to kind of confirm stage, and we'd want to rule out other mixed dementias. We had a lot of lively discussion about the ability to get CSF and plasma-based tests in clinics.
All right, thanks. It looks like we have one more group too.
Just quickly, Christian Lackner, Neuropsychiatry, Mayo, Florida. Our group pretty much had case 2 as well. We agree with what's been said here. We would also like a little bit more information on the syndrome. So MCI, a little more description. We agreed that for the most part, depending on resources, we would consider the positive plasma test as positive. So people from South America, times this is what they may have access to. There's no PET scan, so that would be confirmatory. Other places would go an extra step, whether it's CSF or amyloid PET scan to decipher, and we would provide optimization of risk factors, the vascular risk factors, symptomatic treatments also with cholinesterase inhibitors, and then risk stratification to consider amyloid anti-amyloid therapies.
All right, thank you. Looks like we have time for one more feedback comment.
Okay. Hi, Jared Brush, Indiana University. We had a very practical table. This case didn't include ApoE testing, and before ordering any further tests, we really felt like a discussion, if they were a homozygote, about treatment altogether would drive whether or not we would even order another test. So I thought that was a really important practical discussion that we had at our table, and we were also not clear on whether we would move forward with treatment just based on the plasma tests. There was a lot of debate about that, and we didn't come to a clear consensus there. Thanks.
Did your table, if this patient was homozygous, would your table have then said, we're done?
Quite a few of us said that we would be done potentially at that point, but others said it would involve a very important discussion with the family on risk-benefit as to whether we'd move forward and with which agent.
Thank you.
Okay, very good. Well, that was terrific. Thank you so much for everyone that participated and the facilitators. I thought that worked pretty. We were a little concerned. We're not used to doing these kind of quickie breakouts, and with this larger group, and it was very well done. So thank you, everybody, for participating. We have a couple of minutes left, correct, for Q&A? Or we're the key takeaways?
There are 2 minutes left, and there are questions here.
I'd say let's do the takeaways, and then if
Okay.
people want to stay and ask questions afterwards.
Okay, fine. I mean, I'll just mention one question that here came through the iPad, and this is a good segue to this evening's program. The question is there a more aggressive ARIA monitoring plan for people at higher risk? We need guidance. Personally, I find the risk of symptomatic side effects in E4 homozygotes unacceptable. I do not prescribe amyloid-lowering treatment to these patients. However, they are the ones who may need it the most, which that is the dilemma we're all stuck with. And so very reasonable comment and concern. There's no right or wrong. The FDA label is open. It permits treatment of E4 homozygotes, and so does the appropriate use recommendations. The VA system does not cover treatment for homozygotes, so there's differences of approach. But this will be discussed in greater detail tonight. We're going to spend a fair amount of time on ARIA and be even more interactive with you about cases, and some of them are challenging. And so we welcome your input. I don't think there's a specific guidance about how to monitor differently in terms of number of MRIs or doses or whatever. But I find, and I'm sure my colleagues up here agree, and probably most of you will agree, we're definitely, if we decide, if a person who's E4 homozygote proceeds with treatment, we follow them very carefully. And if they develop ARIA, we're very careful and conservative in the management and about retreating and how often to monitor at that point. So we're especially careful with those at higher risk. And also for excluding, as you referred to, underlying CAA or anything else that might predispose them to more serious reaction. So we take it if we do decide to treat, we take it very seriously. Okay, key takeaways. With multiple approved disease-modifying therapies for AD, it's more important to detect and diagnose early in the disease course. Amyloid PET and CSF are both FDA approved, reimbursed by Medicare, thank God, finally. Although insufficient accessibility to biomarker testing remains a barrier, especially to different regions of the country. Reliability and accuracy of plasma biomarkers are rapidly evolving and improving, and some may be, I would say some are ready for, I would take the may out of that, some are ready for prime time. And please visit us at peerview.com/PACE24. Complete and submit your post-test and evaluation for credit. Download the slides and practice aids. Watch the online activity in the coming weeks. You can join the conversation on X. Thank you for joining us. And please consider coming this evening. It was wonderful to have a filled room today. We'd love to see, we're cooking up some really good dinner tonight, I hear. And so you'll have to find out what that is if you come back. So thanks very much.
Thank you.
Special shout out.
The facilitator?
Yeah, thanks again to all of our facilitators who came from all over the country to participate. So we really appreciate your help with this.
Yeah.